It's a pleasure to be here today to discuss MammaTyper test and its clinical impact on breast cancer molecular subtyping. I think that pathologists who are here probably agree with me that tissue management has experienced slow progress in pathology, and pathologists still face high-impact challenges in the age of molecular medicine. Immunohistochemistry remains a standard diagnostic tool, but it has limitations such as staining variability, inter-observer differences, and difficulty in assessing borderline cases. You know very well that. That means that we need for more precision in molecular breast cancer classification. Over the last years, some advantages have shown up, digital pathology becoming one of the most important. Also, other basic techniques such as multi-gene molecular signatures are here to stay. RT-qPCR provides valuable solutions to immunohistochemistry limits since it's standardized, reproducible, and easily implementable in clinical practice. MammaTyper is, an RT-qPCR diagnostic test for the molecular subtyping breast cancer. It works in paraffin tissue, that is very important, and provides the biomarker value in relation to reference cutoffs. To evaluate real-world application, we were especially interested in answering two main questions. First, which is its concordance with immunohistochemistry, and second, if MammaTyper can improve immunohistochemistry results. In order to answer these questions, we conducted the submarine study, retrospective observational, with special focus in HER2-negative tumors by immunohistochemistry and its possible differentiation as HER2-low or null. Our results show us that the individual biomarker agreement was very high for ER, PR, and HER2-positive cases. However, this study shows differences in Ki67 and HER2-negative values. The discordance in HER sensitivity allows us to differentiate real HER2-null from HER2-low. Taking this data together, the differences appear to be related to MammaTyper's greater sensitivity and objectivity. This suggests that MammaTyper could be a more accurate and reproducible method for the molecular classification of breast cancer. Regarding the molecular subtype, our results show a global concordance between MammaTyper and immunohistochemistry in 76% of cases. The concordance between both techniques was very high in samples identified as HER2-enriched luminal B, HER2 luminal B, and triple-negative. However, again, MammaTyper disagreed on 65% of cases classified as luminal A by immunohistochemistry. Most of the disagreement was caused by discordances in Ki67 evaluation. As conclusions, the global concordance was 76%. Regarding luminal tumors, MammaTyper disagreed on 65% of the cases classified as luminal A by immunohistochemistry. The main cause of discordance was, as previously mentioned, Ki67 value, changing 14 of 34 luminal A as luminal B. So globally, MammaTyper reclassifies 65% of luminal carcinomas from luminal A to B or to B HER2. Also, we observe that MammaTyper is more sensitive than immunohistochemistry for the low hormonal receptor tumors. Regarding HER2, to say that MammaTyper reclassifies 27% of cases in our series, basically from negative by immunohistochemistry to low by MammaTyper. It raises important questions regarding therapy, open the door to scale or dose-scale treatment in certain cases. Also, MammaTyper reclassifies the 15% from triple-negative tumors to luminal B. Finally, as general conclusions, MammaTyper provides a standardized, automated, and reproducible method for breast cancer molecular subtyping, with a strong concordance with immunohistochemistry, particularly from luminal B and HER2-positive cases. MammaTyper also provides a more accurate Ki67 measurement, which allows better subclassification between luminal A and B. and MammaTyper improves identification of hair-loss cases, patient selection for therapy. In plus, it is easily implementable in clinical practice, optimizing as alternative to immunohistochemistry in our setting. Thank you very much.